So we're going to set some things straight about the different kind of metabolic disturbances as far as acidosis and alkalosis. People like to teach things different ways. I think a lot of the ways that a lot of my instructors taught it were really complicated. And so I've broken this down into a much more understandable method, which is really the method that you would use in the hospital. And it actually works on the USMLE. So metabolic disturbances are broken down into acidosis and alkalosis, which the normal range of blood pH is anywhere from 7.35 to 7.45. You'll see different ranges at different places, but this is generally what's accepted on the USMLE. So we're going to focus on the metabolic acidoses, and particularly we're going to talk about the anion gap metabolic acidoses, which are where the anion gap is greater than 14, and the non-anion gap metabolic acidoses, which is where they're less than 14, generally within the range of 8 to 14. So the principles of all the metabolic acidoses in general is that it requires a reduction of blood pH below the normal range, which is 7.35 to 7.45. So the blood pH has to be less than 7.35. That's necessary to diagnose acidosis, regardless of the cause. There are multiple causes, and it causes a clinical syndrome, but that syndrome alone, that's caused from the acidosis, is not enough to find the cause. So you're going to have to look for other symptoms in the patient, other things in their history or physical exam. So the things that acidosis causes is nausea, vomiting, chest pain, tachycardia, and tachypnea. And why is that? Because the body is starving for oxygen. All of these symptoms are very nonspecific, so you're going to have to find, like I said, other symptoms or points in the history that are going to point to what the cause is. History and labs, so therefore, are going to be more important than the specific symptoms, unless you have very, very, very specific symptoms that we'll talk about. You're going to mostly rely on your history and your labs. The most important labs to have are a blood pH. You need to have a metabolic profile with all your electrolytes so you can calculate your anion gap, which should be the first thing you do whenever you have a patient with acidosis. You want to get your arterial blood gases, and then you'll want to have a urine study on this patient. Okay, so this is the question that I hear most often, is how do I diagnose an acid-base disturbance? Because there's metabolic alkalosis, metabolic acidosis, respiratory alkalosis, mixed, compensated, and they all seem very complicated. So let's break this into 5 easy steps. 1. The patient has to have a blood pH. Now, this goes for acidosis or alkalosis. 1. The patient has to have a blood pH of less than 7.35 for acidosis or greater than 7.45. That's obvious. It has to be outside the range of normal. 2. You have to check the bicarb on the patient and the arterial blood gas, the partial pressure of carbon dioxide. You need those two. Apart from those two, nothing else really matters. So your partial pressure of oxygen really isn't that important. You're looking at your bicarb and your partial pressure of CO2. So you have to have those. Once you have those, at least one of those have to be abnormal. It could be both, but they can't both be normal. One of them has to be abnormal. So bicarb, it has to be outside the range of 22 to 28, or PCO2 has to be outside the range of 35 to 45 millimeters of mercury. Now, what you need to keep in mind is that bicarb is a marker for metabolism, and carbon dioxide, as you can imagine, being in what we breathe, is a marker of respiration. So, let's say we know we have acidosis, but we don't know why. What is going to cause acidosis? Is it going to be having a low bicarb, a high bicarb, a low CO2, or a high CO2? Well, you can think back to your equations that the H2O plus CO2 goes to H2CO3 goes to HCO3 plus H. If you remember that equation, that having a low bicarb is acidosis, and having a high CO2 is acidosis. So if you have an acidosis with a low bicarb, then you have a metabolic acidosis. If you have an acidosis with a high PCO2, then you have a respiratory acidosis. So that's as simple as it is, okay? So bicarb is a marker for metabolism, CO2 is a marker for respiration. Now alkalosis, it's the exact opposite. So what causes alkalosis? Well, if you have a high bicarb in your blood. If I were to go down a bunch of calcium bicarb pills, I would probably develop a metabolic alkalosis because my blood bicarb would go up. So a high bicarb or a low CO2. How do you get a low CO2? You hyperventilate yourself. You're getting rid of all that CO2 in your body. Those both cause alkalosis. So you have a patient with alkalosis and they have a high bicarb, you have a metabolic alkalosis. If you have a patient with alkalosis and they have a low PCO2, then they have a respiratory alkalosis. Now, in any patient where they have, and this only applies to patients with metabolic acidosis. If the patient has a metabolic acidosis, then you need to check your serum anion gap. And that's as simple as adding your sodium to your potassium and then subtracting your chlorine. All right, so some people have came to me and have said, what happens if they're both abnormal but in different directions? So let's say that you have a metabolic acidosis. Your bicarb is low and you have acidosis, but your PCO2 is low as well. So if one marker is moved in the direction of acidosis, so a low bicarb, but the other marker is moved in the direction of alkalosis, and your blood is still acidotic, then what you have is still, let's say you have a low bicarb, you still have this metabolic acidosis here, but if the CO2 is low, meaning it's moved into the alkalotic range, then what you still have a metabolic acidosis, but you have compensation from your CO2. So you have a respiratory compensation. Okay, so you still go by this table here to determine your metabolic or respiratory acidosis or alkalosis. But if the other marker has moved in the opposite direction, meaning that it's going towards alkalosis if it's going towards alkaline if you have an acidosis, or it's going towards acid if you have an alkalosis, then what you have is compensation. Now, if both markers are abnormal and they're in the same direction, I don't mean in the same mathematic direction, I don't mean they're both low or they're both high. If they're both abnormal in the same direction of acidity or of alkalinity, then what the patient has is a mixed metabolic respiratory acidosis or alkalosis. So if you have a patient that has both a high bicarb and a low CO2, then what you have is a patient with mixed metabolic respiratory alkalosis, because both the high bicarb and the low CO2 are causing the alkalosis. If you have a patient with a high bicarb and a high CO2 and they have alkalosis, then what you have is a patient that has a high HCO3, or a high bicarb, and they have alkalosis, so they have a metabolic alkalosis, and their CO2 is high, which would cause acidosis, so what that high CO2 is doing is it's compensating. So you have a metabolic alkalosis with respiratory compensation. Okay, so copy and paste this this slide, because this will be good to help you memorize down to make sure that you can diagnose the different kinds of acid-base disturbances, because once you do that, then you'll have your differential diagnosis lined up. So this is the anion gap. It's your sodium plus your potassium. It's the sum of your cations minus the sum of your anions. I think in the previous slide I left out bicarb. That's also important. So you have to have your sodium plus your potassium minus your chlorine plus your bicarb. So these are quantities. So the quantity of your cations minus the quantity of your anions. And normal anion gap is anywhere from 8 to 14. If the gap is greater than 14 and you have a metabolic acidosis, then you have a anion gap metabolic acidosis. So here are the two different kinds of metabolic acidosis. Like I said, we got the normal anion gap metabolic acidosis, or the non-anion gap metabolic acidosis. And the two major causes are renal tubular acidosis, which I talk about in a different section, and that's just a disorder of the channels. And diarrhea is a cause of non-anion gap metabolic acidosis. There's also the use of lithium can cause a metabolic acidosis, but we don't really see that because it doesn't really present with symptoms. And if a patient has low albumin, in, for instance, the event that they have nephrotic syndrome, they can develop a metabolic acidosis, in which case you would actually see a very somewhat low anion gap, maybe even below 8. We don't really talk about the ones I didn't boldface. You don't really see too much, so I wouldn't be so concerned about those. What I would be concerned about, though, is the causes of anion gap metabolic acidosis, and that you can remember in the mnemonic mud piles. So we've got methanol intoxication, uremia, diabetic ketoacidosis, propylene glycol intoxication, isopropyl alcohol intoxication, lactic acidosis, ethylene glycol intoxication, and overdose of salicylates. And most commonly, that's going to be aspirin. So let's start with methanol intoxication. So the cause, of course, is the ingestion of methanol. And methanol is converted by alcohol dehydrogenase, so the same enzyme we use to break down the alcohol that we drink in our beer and wine. Methanol is broken down into formic acid, or formate, by that enzyme. And formate is a neurotoxin, and particularly it damages the optic nerve. So these patients, they usually have a psych history or a history of alcoholism, and they got drunk on some bad liquor, maybe even moonshine or homemade liquor, and now they're presenting to the ED, or they've been brought in with suddenly decreased visual acuity. They may have behavior similar to ethanol inebriation, to regular old alcohol inebriation. And of course, they'll have symptoms related to acidemia and possibly altered mental status. But the most important thing, the one that distinguishes this apart, is the decreased visual acuity, or blindness. So on physical exam, you're going to have a patient with somewhat of an altered mental status. They may just seem drunk, they may have stupor, or they may even be comatose, depending on how bad the acidemia is. What you will see universally in patients with methanol intoxication is you're going to see decreased pupillary reaction to light, and that's characteristic of the damage to their nerve. And on fundoscopic exam, you'll see optic disc hyperemia. The USMLE might throw that at you. The diagnosis for this, you need to have a high level of suspicion. As if they have the visual symptoms or the symptoms on fundoscopic exam, plus they have the anion gap metabolic acidosis, that's going to be enough to start treatment. You're going to want to start treatment as soon as you can with these patients, because the faster you start treatment, the better their outcome is going to be. So you can get a serum methanol level for a definitive diagnosis, but as soon as you have these symptoms and you know that they've got an anion gap metabolic acidosis from your CMP, then you're going to jump right into treating these patients. First of all, of course, you're going to want to manage their ABCs. Generally, these patients are stable, but if they are comatose or in stupor or they're sleeping, you're going to want to make sure that they have a good breathing line. Airway has to be managed all the time. What you're going to start on these patients then is IV ethanol or IV fomepizole. What those do is they inhibit or saturate the alcohol dehydrogenase, which will reduce, because methanol itself isn't toxic, it's what methanol gets converted into. So if we saturate that enzyme that converts methanol to formic acid, then what we do is we reduce the amount of toxins circulating around. So we want to either directly inhibit or competitively inhibit that enzyme. So we can use either IV ethanol or fomepizole. And then we should start maintenance line fluids to these patients, and we can use D5 half normal saline. Of course, we'll also want to use thiamine because these patients usually have a history of alcoholism, and we can consider adding bicarb to our fluids. But most importantly for the USMLE, they're going to want you to know that you need to use either IV ethanol or fomepizole for these patients to reduce the amount of toxins that are developing and to better their outcome. You're also going to want to keep an eye on their serum amylase because about half of patients that develop severe methanol intoxications do go on to develop hemorrhagic pancreatitis, which is a problem in and of itself. So uremia is another cause of metabolic acidosis, and we're not really going to talk about that here since I kind of brought that up on the chronic kidney disease section. Acidosis is always an indication for dialysis if the patient has renal dysfunction. So definitely if the patient has an elevated BUN and creatinine and they don't fit any of the other mud piles, symptoms or disorders, if they have an anion gap metabolic acidosis and they have kidney disease, go ahead and start dialysis on these patients. Diabetic ketoacidosis, so these are patients, usually they're kids, and they have a deficiency of insulin because they have diabetes type 1. And what happens from that is they then have a cellular glucose deprivation. So I'm not saying that they don't have glucose circulating around in their blood, they do. But because they have low to no insulin, their cells have no way of bringing that glucose in from the blood into the cells. So as far as their cells are concerned, they're starving. So the cells are going to trigger gluconeogenesis and lipolysis. Gluconeogenesis, of course, being the breakdown of glycogen, lipolysis being the breakdown of fat. When you break down fat, what you develop are ketone bodies, and those can accumulate in the blood, and resultantly they cause a drop in pH in the blood. Ketone bodies can also spill out in the urine, and generally by the time diabetic ketoacidosis is symptomatic, there already are ketones in the urine. So some of the history or symptoms here, a lot of times you're going to see this in a pediatric patient when it's presented to you on the USMLE, but it doesn't have to be. These patients are going to have nausea and vomiting. They're going to have a history of abdominal pain. And what's really key here is that they have polydipsia, polyuria, and polyphagia. What does that mean? Polydipsia means they're very, very, very thirsty. Polyuria means they're peeing a lot. And polyphagia means they're very hungry. So why are they drinking a lot? Well, they're drinking a lot because they're peeing a lot. Why are they peeing a lot? Well, they've got glucose and ketone bodies spilling into their urine. And what does that do? That draws water out of the blood. And so you have a high urinary volume. And so because you have the polyuria, you're really thirsty. Because you're peeing a lot, you're drinking a lot. And polyphagia, because as far as their body is concerned, they're starving. They may have a glucose count of 1,000, but as far as their body is concerned, they're in starvation mode. So they'll also usually have symptoms consistent with dehydration just because they're urinating out so much, and they may have, I didn't put it here, I don't know why, they may have concomitant infection, so that should say infection right there, and write anything. Usually the infection will trigger the diabetic ketoacidosis in a patient that already has subclinical diabetes mellitus type 1. So in order to diagnose this, if you see, again, you need to have a high index of suspicion. If you see a patient with hypovolemia and hyperglycemia, and the patient also has anion gap metabolic acidosis, DKA is your presumptive diagnosis. You really have to have a high index of suspicion here because this can be deadly. So your CMP will often show hyponatremia and hyperkalemia, and that's simply because you don't have insulin. And insulin draws in glucose and potassium into the cells. So because you're not drawing in glucose and potassium, you're going to have both a hyperglycemia and a hyperkalemia. A lot of times you're going to have the hyponatremia just because you're peeing out so much, and so you're losing sodium. And then, of course, you're going to have a very, very high blood glucose level. Urinalysis will often show, well, actually, it'll always show positive ketones and positive glucose, and your CBC will show an increased white count. That can be indicative of an infection, but a lot of times it can just follow the DKA. If the patient has increased neutrophils, then definitely think about an infection. And in any patient with DKA, always look for an infectious source. So the treatment for these patients, first and foremost, is to correct their fluid loss. Fluid loss is always most important. So you want to start them out with a bolus or two of normal saline immediately, and then every hour after that until you can see that the patient is euvolemic, their blood pressure is good, they're peeing the normal amount. And then after that, you can switch them to maintenance. Then what we can do is we can switch them to a short-acting insulin drip while we have them on maintenance fluids. We want to drop their insulin by approximately 100 points per hour. And at the same time, we want to watch the potassium levels because remember, as we're drawing in that sugar now, we're going to be drawing in potassium. So we want to supplement potassium if their potassium levels get too low. And of course, we want to treat any underlying infections. So that's just kind of the overall of how we treat DKA. We'll go into it more in depth when we talk about endocrine disorders. Propylene glycol intoxication is rare. It's found in solvents and preservatives to cigarettes and other industrial uses. It's even found in very small amounts in some of our food. Small amounts of propylene glycol are perfectly safe. So really the only time we see this is when a parent might have propylene glycol in the house for one reason or another, or a kid gets into it or something of that nature. Usually on the USMLE, you're going to be told, even in a patient's history, you're going to be told something about propylene glycol or something about solvents. So I wouldn't expect to see this on the USMLE because the only time this really happens is in very specialized circumstances because not many people keep propylene glycol around. So if it's part of the history, then definitely think about it, but it's uncommon overall. And the way we treat this is just with fluids and dialysis. Isopropyl alcohol, on the other hand, is very common. That's going to be your rubbing alcohol. And usually the people who ingest isopropyl alcohol are either young kids who get into the medicine cabinet. They could be teenagers who want to drink alcohol and they think that isopropyl alcohol is the same as vodka, which it's of course not. Or they could be people who are suicidal. Either way, isopropyl alcohol is converted by alcohol dehydrogenase into acetone. And so what happens then is you develop a metabolic acidosis. Another characteristic thing about isopropyl alcohol is that isopropyl alcohol has an irritating effect on the gastric mucosa. So the symptoms here are very similar to a patient with ethanol intoxication. So it's going to be very similar to just your drunks who come in. And it's kind of hard to discern the two. So the best way you're going to get it on the USMLE is that the patient has just had hematemesis, or the patient has a nail polish or fruity odor on their breath. And I would look more towards the fruity odor on their breath in a patient that came in intoxicated, particularly a teenager. I wouldn't think so much of the hematemesis. On the USMLE, when you get hematemesis in association with a patient being drunk, usually that's going to be a Mallory-Weiss tear or an esophageal tear or a rupture. So don't so much associate with hematemesis. Associate it with this fruity odor on the breath, because what that is it's the isopropyl alcohol and the acetone that gets converted to. So unlike any patient that comes in with alcohol, when I say alcohol, I just mean regular, like ethanol, vodka intoxication, your metabolic profile on patients with isopropyl alcohol intoxication will show an anion gap metabolic acidosis. So that's going to be a must in order to diagnose isopropyl alcohol intoxication. The treatment here is just going to be supportive and observation, because apart from the metabolic acidosis, the byproduct doesn't really pose a huge threat. So if there has been hematemesis, you can start a PPI, so like omeprazole or lansoprazole, and then you can also get an EGD on these patients to see if there's any rupture in the gastric mucosa. But for the most part, you're just going to give these patients supportive therapy, probably fluids, and observe them. So definitely have an eye out for that nail polish or fruity odor on the breath of a patient with anion gap metabolic acidosis. And unlike the patient with DKA, where you have that same fruity odor, these patients will have a normal glucose. Lactic acidosis has many causes. The most common that you'll see is shock. What happens in shock, of course, is you're getting decreased perfusion to the tissues, and when you get decreased oxygen to the tissues, the cells are going to go into anaerobic metabolism, and as we remember, what's the product of anaerobic metabolism? It's lactic acid. So the symptoms you want to look for in these patients is any symptom consistent with sepsis, which would be a bacterial illness or fever, cardiogenic shock, which would be edema and dyspnea, or hypovolemia, so symptoms of bleeding or dehydration. And you're going to see pale, cool extremities in these patients. On physical exam, understandably, you'll see hypotension and tachypnea. If they do have sepsis, you may see fever or hypothermia, and the exam is going to be consistent with shock. You actually will see altered mental status. You'll see poor capillary refill and oliguria. Definitely here keep a high profile of suspicion for acidosis in any patient who's hypotensive or has an altered mental status. Since your complete metabolic profile should be part of your workup in hypotension, you will see the anion gap metabolic acidosis when the patient has lactic acidosis. So basically what you're going to have here is a patient that's got hypotension, you do your basic set of labs, and then all of a sudden you see they've got a metabolic acidosis. At that point, barring any other symptoms that might point you to any of the other causes of anion gap metabolic acidosis, your first thought should be lactic acidosis. And what you need to do here, and you know this before you even diagnose the lactic acidosis, is that you need to focus on maintaining volume. So if they're septic, if they have cardiogenic shock, if they have hypovolemic shock, if they have the pale, cool extremities, you've got to maintain their volume. So give general normal saline boluses to keep their blood pressure up while you work on trying to find the diagnosis. You should supplement fluids with thiamine if possible. That's been clinically proven to be useful and improve outcome. And avoid vasopressors just simply because we don't want to constrict the capillaries that provide perfusion to these patients. So we want to focus on maintaining volume at all times when we're suspecting shock, which may cause lactic acidosis, and the lactic acidosis would manifest itself in your electrolytes and in your blood pH. Ethylene glycol intoxication is very common. What it is antifreeze, and so you're usually going to see this in a child, which would be accidental, or you could see it in an adult as a suicide attempt. I suppose it could be accidental too, but usually it's going to be a suicide attempt in an adult. Ethylene glycol is also converted by alcohol dehydrogenase. It's converted to glycolate, and this causes acidemia. It also causes the accumulation of renal stones. So what's going to be particular here in ethylene glycol is that you're going to have symptoms that start within 1 to 4 hours, so pretty immediate, and it's going to involve a severe acidosis. You're going to have a reduction in renal function and altered mental status. And usually these patients present to the ED unconscious. And sadly, most of these patients don't even present at all. So diagnosis, you can probably see a pattern here. You're going to have an unconscious patient, so you're going to want to get your basic workups. CMP is going to be what the USMLE is going to give you, and of course, the wards in the ED, you're going to want to get your CMP, but on the USMLE, you'll be given your CMP, you'll see a anion gap metabolic acidosis, and it's going to want to know why. Usually, they're going to have to give you something else. So usually, the urine will show the ethylene glycol crystals, which are just really calcium oxalate crystals, what they look like. But unfortunately, that's usually going to be later on in the course of their ethylene glycol intoxication. So while the USMLE may say they have crystals and they have renal failure, what you may see and what the USMLE may throw you as a more less tested cause, but certainly more clinically seen, is that you'll have a low serum calcium in addition to their anion gap metabolic acidosis. So if you have a low serum calcium and an anion gap metabolic acidosis, definitely think ethylene glycol poisoning. But a lot of times you'll get the ethylene glycol poisoning in your history. So the way to treat this is with generous IV fluids at a fast rate, and I emphasize a fast rate here because that's going to help work out the stones out of the kidneys, and that's really important in order to maintain function, because remember, if we have generalized renal stones on both sides, what we're getting is a post-renal failure. So we want to pump we're going to want to pump these stones out as fast as we can. You should add thiamine to any fluids. Anytime you have a possibly suicidal patient, likely they have a history of alcoholism, so you're going to want to add thiamine to prevent Wernicke-Korsakoff syndrome. Start IV ethanol or fomepizole to reduce the further conversion of ethylene glycol into glycolate. And then, of course, because these patients have a low serum calcium, they're at risk of arrhythmia, so you'll want to have these patients on tele. And this is an ethylene glycol stone. It's really just your envelope stone, looks nothing different than a calcium oxalate stone. So salicylates are aspirin, and this is a very common suicide attempt. So overingestion of salicylate, it has an overall complex mechanism. It dissociates ATP, it acts as a catabolic, it acts as a gastric irritant, a neurotoxic, and a hepatotoxic. This should also be high on your radar if a patient has metabolic acidosis. But what's really going to tip you off is if the patient has a decreased sense of hearing, so particularly tinnitus, so the ringing in the ears, and if they have tachycardia and tachypnea. They may also have nausea and vomiting. So decreased hearing, tachypnea, tachycardia, abdominal pain, nausea, or vomiting. The CMP will show an anion gap metabolic acidosis, and anytime you have a history of aspirin overdose, or the patient was found by EMT to be next to an empty bottle of aspirin, or the patient has tinnitus or other characteristic symptoms, this is a presumptive diagnosis. So we need to keep our index of suspicion high here, because how quickly we start treatment is going to affect the outcome. So the best way to treat these patients is with gastric lavage, but you can also use activated charcoal if you're within 1 hour of ingesting. You're going to want to start IV fluids and add sodium bicarb. You can also add sodium or potassium chloride if the patient is hypokalemic. And why we want to use sodium bicarb and potassium chloride is because the two of these are going to alkalize the urine. And if we alkalize the urine, it's going to promote the excretion of salicylates. So you're going to get rid of the overdose salicylates quicker. So just kind of an overview of the anion gap metabolic acidoses. Methanol primarily presents in alcoholics. They're going to have visual deficits and appear inebriated. You may hear a history of them using moonshine or homemade alcohol. And the treatment is IV ethanol or fomepizole. Uremia, you're going to have patients with renal disorder. The peculiarities is that they're going to have labs that suggest renal disease, and the treatment is dialysis. DKA is going to be pediatrics. Diabetics, it could also be in adults, but it's more common to happen in pediatrics. Peculiarities is going to be hyperglycemia and a fruity odor on their breath. Treatment here is generous fluid replacement and then your fast-acting insulin. Propylene Glycol intoxication you're going to see in pediatrics and in industrial settings. The peculiarities for this will be mentioned in the history that they have had propylene glycol intoxication. So what you're really just going to need to know here is that you need to start IV ethanol or fomepizole therapy. Isopropyl alcohol you'll see in alcoholics, teenagers, suicidal patients. The peculiarity here is that you'll also have a fruity odor, but you'll also likely have hematemesis and a normal blood glucose. And the treatment here is going to be IV ethanol or fomepizole. You can see anything that's an alcohol that's an overdose, you're going to want to start IV ethanol or fomepizole. And then proton pump inhibitor like omeprazole, and that's just for the protection of the gastric mucosa. If the patient has, if it's lactic acid, these are usually going to be patients with shock. And what you're going to see here is hypotension, cool and cold extremities, blue extremities possibly, numb or pale extremities. What you're going to want to do here, of course, is rapid emergent fluid replacement. And then for ethylene glycol, which is the antifreeze, these are usually going to be kids or they're going to be suicidal people. And the peculiarities here is going to be a low calcium, and you'll have the crystals that develop from the ethylene glycol. And you're going to want to start IV ethanol or fomepizole and generous fluids to pump out the crystals to prevent any permanent renal damage. Salicylates you'll see in suicidal patients or in patients with chronic pain who just happen to take too much. The peculiarities here are going to be tinnitus and abdominal pain, and the treatment is going to be gastric lavage or activated charcoal. The reason I put a star up here is because I put fluid replacement or IV fluids in a lot of these, but in general, you're going to want to start IV fluids in all of these patients, but particularly in the ones that I noted. And that is the end of metabolic acidosis.